Please give me 2 minutes.
Yes.
Give me 5 minutes.
Okay.
Okay.
Animal cookies. This is universal, I think.
What's that? Biscuit cookies?
Animal-shaped cookies. Little dogs.
Okay, Pedro, we can start.
Okay, okay.
Yeah. Can share your screen.
Hello, good morning, everybody. Would you make an introduction or do you want us to start working?
Okay, Pedro, we can start.
Okay, okay. Good morning, everybody. It's a honor and a pleasure always to be a part of this good, excellent initiative from Mark to bring good ultrasound anywhere. And we will start talking today on normal female pelvis. I invited for a good reason, I invited this lady here to share with us some things. She's my sister. She's one of the most renowned gynecologists here in town. And she has a very, very good eye and an excellent device to participate with recent and great material to share with us. As I say, the world does not need you to do excellent things, but to do whatever you do in an excellent manner. And I think this is what we are trying to do now. I asked my sister, hey, Maria Elena, would you send me some pictures, some recent pictures then? This is from yesterday. Yesterday, she started flooding my WhatsApp with pictures. Then she sent this. We will explode each picture in all the features we can. There is not a perfect observer. There is no perfect observer, nor mechanical, nor human. But we all can get information from images. The human eye is sensitive to something between 8 and 16 shades of gray. But after we pass through this, I promise you, you will manage like 64 at least. Let's see. This is an image obtained by an endovaginal approach. This is the probe of a uterus. And as my sister Marilena said, this is normal, very normal. A little bit more flexed than usual uterus. This is the vaginal wall, and this is the fundus of the uterus. She's orienting the image with the surface of the skin of the patient on this side, the rectum on this side, and this is the cervix, the isthmus, the endometrial line, and then the myometry. We here in ultrasound, you know that we play with the difference on speed of sound transmission through the soft tissues of the human body. So the harder, generally speaking, the harder the surface, the higher the speed of transmission of the sound. But here we have brighter white areas which are outside the uterus and are not bone, but air and intestine and other things. This is a picture from yesterday. She plays with her fancy machine. No, there's not like a fancy machine in the hands of everybody, but she's very good in reconstruction and rendering on gynecology and obstetrics. And as we can see, this is the image corresponding to that nice, considered normal uterus. This is still intro to the speech. This is another picture from same day, yesterday, with a uterus. Now she oriented the transducer in the opposite manner. As you can notice, the fundus of the uterus is on the other side. So unless this is an extremely retroverted uterus, we can assume that she's orienting the patient's skin to this side and the rectum to this side. That's not critical, but for our brains, it's very important to figure out how we are orienting the images. See the date and time? This is fresh new. When we are in medical attention, we see people, all kind of problems, people and worries every single day. This is the 3D reconstruction of that normal image. And this is me. I'm more a normal guy than here. I don't have that fancy machine, but this is a portable ultrasound, an M7, with a good image. You don't need more. Let's see what I do. I swap through the pelvis of a patient. The name of the patient is erased here, but see, time and date. See, this was yesterday's. Once more. The transducer is lying above the pubic bone. Pubic bone this side. Patient's skin, fat, muscle, urinary bladder. Don't miss details. Urinary bladder with some thickening on the wall. Vagina on this side, cervix on this side, and the uterine contour. For most problems, this is enough. We don't need the fancy machinery for most things, particularly if we are not a referral institution. What did I saw in that simple sagittal and parasagittal plane above the pubic bone swell? See, that was an ovary. That's the uterus. That's an ovary with the follicles and everything. What we see surrounding the uterus? Air on the intestine. Air on the intestine and some intestinal echoes and part of the ovary. One side, the ovary is nearby the uterine horn with the small follicles. And on the opposite side, the ovary is lateral to the uterus. What was this patient problem? She ran a urine sample pregnancy test, became slightly positive, then went to the lab and it went negative. Then she started menstruating. If we take the transducer transverse upside down from the uterine fundus to the almost empty bladder, we see several details. First of all, we don't need like that mandatory need a fourth bladder in order to have diagnostic information. Sometimes there's 3 lines in any place, in any hospital. One line of ladies drinking water, one line of ladies waiting for the ultrasound, and a third line, crowded, ladies jumping and almost screaming, waiting for entering to the bathroom. You can see that in any travel and in any hospital which performs a lot of ultrasounds. Sometimes you have to do what you have to do with the things and the situations you have. So many patients have to be seen with an empty bladder. Right ovary, left ovary was up here, and then this is the transverse cut of the uterus. This is not an ideal imaginary, but for purposes of giving you the idea of what could we do, this is enough. Again, the bladder with a somehow thick wall, which can suggest a cystitis. Why we perform female pelvic ultrasound examinations? Usually we have some reason why. Reason for pelvic ultrasound examination can be menstrual delay, pelvic pain, abnormal bleeding, or suspicious pelvic mass. I think number one cause of ultrasounding a female pelvis is pelvic pain. Ladies come in and say, my ovaries hurt, but almost always number one cause of pelvic pain is not ovarian pain, but pain from other organs. And I highlight these words to make us think. What's the most important concept here? What's the main concept? Ultrasound? The machine we own or we we just play with our skill and will to be of some help, the reason why the person came in or the problem she thinks she has or in fact she has. Well, let me tell you, from my point of view, this is the most important word. We see persons, human beings. Yes, we are ultrasound skilled professionals, but we see persons. It's not a number, it's not even a patient. It's somebody who has a reason to worry and thinks she has a problem. And if she thinks she has a problem, she has a problem. Back on topic, images. Don't forget, she's a lady and she's a human being. I will ask you to notice the difference between these two videos. The one on the left side. The one on the right side. Look at the timing, 5 minutes apart. Same patient. Same anatomy. A little tilted. Not identical cuts or images, but fairly close. We can have diagnostic information from both. But one is better than the other. So this is not a pregnant lady. Why to use an obstetric setup? Same transducer, different setup. This is a gynecological setup. This is an obstetric setup. The brightness, the gain, and the quality of the image is different. So, tip number one, use the proper setup. You don't have to play much and be an expert on the knobs of the machine, whatever machine you have, in order to click on gynecology whenever you are looking to a non-pregnant pelvis, obstetrics whenever you're looking to pregnant pelvis, abdominal whenever you're looking to other organs. So let me share with you. I've been for 39 years, 37 of which I've been to ultrasound diagnosis, and I've been living on this town for 20 years. We have 140,000 population here, and I've seen around 25,000 of them. I have this many contacts on my cell phone, mostly patients. with all the proportion, you have an impact, you have a social impact. If you see people and are willing to make a better health for that people, you have a social impact. Many of you higher than mine, some of you lower numbers, but the same impact. Each person who enters to your facility and asks or needs an ultrasound examination is not part of these numbers, but is your social, universal, worldly impact. So let's make a good impact on that. This is about becoming part of the solution for our people, our brothers and sisters, not to be a part of the problem. Sometimes we are a part of the problem. We have a big mouth. You can see two images here. This is one on the left side. Same lady, yesterday's lady, same transducer, same setup, and one on the right side. Same lady, same transducer, same setup. There are differences between the images. What's the difference between the images? The depth. Here we are looking at 15 plus centimeters depth. We don't need that. This is a tiny, skinny person. And what we are, the area of interest is here, like a 5 to 10 centimeters depth. So, tip number 2, after choosing the right transducer, the right setup, focus the resources of your machinery in the body parts you wish to investigate. We have more detail if we put all the resources of the machine here. See the ovary, the follicles. We can zoom in, but adjusting the depth is not zooming in, it's not sacrificing resources, it's making the same pixels to work on the proper place we want info to get for diagnostic purposes. So very important, keep your depth on the field that you are interested to investigate. So, the right transducer. For pelvic examination, we can use several kinds of transducers. The endocavitary probe, which is the best for many instances because it gives us a closer look of the organs of the female pelvis without interference of the intestine, air, and subcutaneous fat. nowadays that we have an epidemics on metabolic syndrome and obesity. In fact, we are on this state, we are like number 1 or 2, depending on the year, of obesity in women of the world. So we deal with really big patients sometimes, and we must use the vaginal approach in order to investigate the uterus. But sometimes I play with the transducer, which I call the Barbie doll transducer, which is the linear transducer. This fast lady is tiny, and I could be able to search the endometrium with the linear transducer because it was closer from the surface of the pelvis skin than from the vagina. That's why I didn't use the transvaginal approach with her. You have to be specific. There's a specific transducer for each person, not just for each application. Sometimes I got better images with the volumetric heavy transducer because the elements of the volumetric transducer are several transducers inside a machine. And for some images, you have clearer pictures of details with that kind of transducer. Sometimes it's enough with the typical convex 3.5 to 7.5 megahertz or 5 to 7 megahertz to get good images on a female pelvis. So the right transducer depends on the situation or depends on what you have in hand. The right setup, pick gynecology if you are trying to investigate gynecological stuff. If I put my endovaginal probe in the machine of my cardiologist brother, the machine will think that I'm using a transesophageal probe, and the setup is not going to be the proper setup for the examination. So we have probes for almost any application, and there's a setup for each of the applications of the probe. The right gain, the gain is like the volume of sound you are detecting, and the more gain, the brighter the screen. Sometimes there's one set of gain for looking at and a slightly different one for printing it. You can play somehow with the images on post-processing on the paper if you want to print brighter images. But it's easier to play a little bit with the gain on the machine. And of course, as I told you before, sorry about that, it's not COVID, the depth you're playing in. Concentrate the efforts and the resources of your machine on the proper depth. Now I will show you this in order to understand how we correlate vaginal and transpelvic views. Here, we are using an endocavitary probe with the fundus pointing to the skin of the patient. If we tilt this, if we twist it, if we rotate, put the fundus up, and if we had the proper or the standard orientation of the transducer, we will orient the patient's skin here. In our brains, This is in our brain in order to understand what's left and what's right on the screen. We should do this in our brains. Oh, okay. That's the way we are looking at the pelvis. If we took the transducer upside down, just mirror it. It's the same image, just mirror it. At the end, orientation if the uterus will be most commonly fundus up, fundus up. This is up, anterior surface of the skin. This is vagina. This is vagina. This is the transducer. This is the transducer. Here, transducer is here or here. We just tilted the image. So, what's normal? You got me into troubles if you ask me to talk about normal female pelvis. Well, normal is what is more usual. What is the most usual thing we can see on a female pelvis? Of course, the most usual things we see is not normality, but this is kind of a normal uterus. No evident masses, a well-defined serosa, outer layer of the uterus. No masses on the myometria, unless you notice this, but consider it normal. If you really get picky, you can tell, well, here we have small, rounded, somehow irregular like images. But if the patient doesn't have abnormal bleeding and is coming from a general checkup of how the internal organs are, you find this like normal respiratory stage endometrium. Remember, we all are alike, but we all are unique. Every single image of every single organ is different to another. And we can spot different things. This is an image where we can find normality with some things that are not information we seek for, like some intestinal echoes and almost nothing fluid inside the pelvis, which is normal. Again, almost everybody has this amount of fluid inside the pelvis, male and female, but particularly female. We are all alike, but unique. And you know what? There is not such thing as perfection. Well, you're perfect. Fine. I am perfect. But whenever we talk about ourselves, we are perfect. Especially if we are on the health profession, we don't have perfect patients. because we see them as patients, as problems, as things to fix. We see persons, everybody's perfect with differences. So what's considered to be normal? Well, we consider normal what is the usual. Anyway, most uterus have some fibroids, sometimes small, non-relevant, not quite masses. But most uterus have some fibroids. So let me ask you, think by yourselves, are fibroids normal? If most uteri has some small or medium-sized fibroids, fibroids could be considered normal, unless the patient has a problem due to the fibroid. Many uteri have slight variations of shape. As my father says, when you perform a C-section, take out the baby and clean up the endometrial cavity, almost every single uterus feels like a slightly bicornuate uterus. Not like this, which is tabicated uterus. You can see the notch here above. And with the rotation of the angle, an empty cavity and a second cavity with a gestational sac. How abnormal is this? I can tell you these patients went all the way to the 40th week without a problem, because the uterus is made for that. It's an elastic thing with compliance that can grow up and be fulfilled by a 3.5 kilos baby, even if it's not perfect. So many uterus are slightly bicornuate or more than slightly bicornuate. Again, what is normal? Is it normal a slightly arch or somehow bicornuate uterus? It is normal because we don't know how the uterus is shaped. Many patients have 3, 4, 5, 6 kids without problems. I have abnormally labeled uterine shape. What is normal then? Again, Mark, you have been into troubles trying to speak about normal female pelvis. Well, it depends on the clinical scope. Remember, female pelvis examination is performed usually because of some reason why. It can be menstrual delay, pelvic pain, normal bleeding, pelvic mass. Most common reason of menstrual delay, pregnancy. Sometimes early pregnancy, which can be lost in 70% of instances if we really take in count all the biochemical pregnancies which are not diagnosed unless they have a pregnancy test. People that has a pregnancy test positive, then have menstruation. But not every single menstrual delay is a pregnancy. With the polycystic ovarian disease epidemics, which is related, highly related to the obesity and metabolic syndrome epidemic, that's number 2 reason of menstrual delay. Pelvic pain. The most usual reason for pelvic pain is not ovary, but intestine, colitis, irritable bowel. The life we are living through, the things that we get into our systems, the acid, vinegar, junk food, bread, dairy products, and worries. Remember, women are warriors. They worry about everything. And that's not a personal problem. That's like a universal problem. I call it colitis vulgaris variety feminis. Anyway, abnormal bleeding is another cause of examination, and usually can be anything between high physical activity, jumping too much, heavy intercourse, taking the day after pill, having an IUD, or just hormones getting a little bit crazy. Not necessarily an endometrial cancer or abnormality. And a pelvic mass, which for good is not a very, very, very common reason of this. Usually people feels like a mass and have nothing but an inflamed colon. Let's call that the problem. What's the problem that makes people go for a pelvic ultrasound? Any of this. Here. Again, same lady. The problem was positive pregnancy test, then negative, then menstruation. A little or somehow heavier than usual. Sorry about the typo here. What we have here? A non-enlarged uterus with a normal menstrual endometrium, no collection inside, and that mild cystitis that we can see in the thickening on the bladder wall. We see a non-enlarged uterus with a lady who is menstruating after a positive and negative test, or even a positive which keeps positive for 2 or 3 weeks. You can call this a biochemical pregnancy, but careful. Remember, the most important factor to consider here is the person. If you tell this person she was pregnant and she's not, you and I are becoming a part of the problem. So we have to be careful on what we communicate and how we communicate and how clear we are. The ovaries, by the way, are normal multifollicular ovaries, not purely dark or purely bright, but with small follicles that makes them to look like this. if I don't explain here, you know what? Technically speaking and humanly speaking, you should not go and message your mom and say, I just had a miscarriage. This has very many implications. It's not a matter of that I know what happened with my ego and my skill and my knowledge. This is, I can tell you what happened with the whole explanation and a suggestion on what and how to manage that. You know that this happens to 70% of people? Well, no, I didn't know that. Well, you didn't know that because you're not into the reproduction business, but that's the truth. Most people get pregnant and most pregnancies are lost. That's why we are so perfect. But because remember, you were one out of like 100,000 sperm chasing your mother's egg, and you know who won that race? You. So it's harder to be born than to win the Europe lottery or the lotto or whatever. We have an empty uterus, no free fluid, no pelvic mass, no problem. We have to be very careful on what we communicate, especially, particularly, we have a no problem situation. We have to make an effort to explain the person in front of us, looking at our eyes and a mask. I don't wear a mask, I wear a shield because that way they can look at my eyes and my face and my gestures. Then back to the topic, we have to explain on our best knowledge in good and in a good mood what happened without causing a secondary additional problem to that patient who comes for help. Enough of normal uterus then. What about ovaries? Well, my sister says this is the right ovary. Let's take her word for that. This is an ovary. Nice. Seen by transvaginal approach through the uterus, which shows more or less normal. If you get picky, you can spot small, really small fibroids here. And if the patient has abnormal bleeding, you can say, you know, you have small fibroids. We have a big mouth, remember, again, we have a big mouth. We are sometimes part of the problem with our mouths. And some small follicles in a otherwise normal ovary. Usually normal ovaries are around 4 centimeters wide. The wider or longer diameter is like 4 centimeters. More than that if the ovary is polycystic or pre-ovulatory or has a luteum, corporal luteum active. And there are all kinds of ovaries. This is like tacos, chili, sweet, plain tortilla, all kinds of ovaries among normality, almond shaped with some follicles on and no masses things seen around. this doesn't show the follicles as nice as the other one, but this is still a normal ovary, almond shape, small, not enlarged ovary, not twisted. Even if we don't use Doppler color, twisted ovaries usually have some free fluid surrounding them. Here we have both, the right and the left. So whenever people has pelvic or low abdominal pain and say, oh, my ovaries hurt, they think the ovaries are like in the pictures, nicely set, each side of the uterus, each side of the midline above the pubic bone. That's not true. This is an ovary which is behind the uterus, somehow behind the uterus. This is an ovary which is by the side of the uterus. So I tell people, well, ovaries are not fixed organs. They are hanging like fruits on a tree. They can be above the uterus, behind the uterus, even on the opposite side. If you don't find the ovary on the place that you think it should be, think twice. Ovaries deserve or have the right to be anywhere on the pelvis, even up high. And we were talking about the epidemics of metabolic syndrome, obesity, and polycystic ovarian disease. This is a very clearly polycystic ovarian disease patient with more follicles than other things. Is that normal? Because it's becoming the most common thing. And remember, we consider normal the common things. That's not always true. This shouldn't be considered normal. It's a problem. It becomes a problem when you start having menstrual delays, then want to have a children and are making the thing that you have to make children. And there's 1 year, 2 years, 3 years and nothing. And this still is a normal ovary, slightly more than 4 centimeters wide, with a dominant follicle, follicles sometimes low or ovaries ovulate, anywhere between 25 and 30 millimeters wide. This is like a 30 something millimeters small, seen through vaginal approach, but still small, fluid filled thing inside an otherwise normal ovary. This should not be considered as a cyst. If we open our mouth and say, oh, see, you have small cyst on the ovaries, there you go. We are not anymore part of the solution. We can become a part of the problem. We can explain that the name of that is a follicle and is part of the normal function of any ovary on the world. That each lady is born with like 300,000 of those for the whole reproductive years to function. Some get lost, some get pregnant. That's it. Normal follicle. Message. Care the person, not the problem. She's not a problem. She's not a number. She's not your patient. She's a person. And care for the person, especially if no problem found. With, without, and regardless the problem found. And if you agree, we're ready for a short break, 5 minutes. How about that, Mark? Coffee break. Five minutes to Dr. Pedro to drink some water or some more coffee. See you in 5. I wanted myself to be a doctor as fast as possible. Then I went to train for ultrasound imaging to a Mexico City hospital with 100 patients a day. We used to see 100 patients a day between 3 machines. That means 30 patients each person on the special or pathological or abnormal problems to be seen by the 3 of us. You end learning by flooding. Sometimes you have no social workload to learn from. Somehow you start doing things on a lazy manner, and you don't know what Michael Jordan said. If you learn how to shot wrong, and you shot wrong, the wrong shot 10,000 times, you learn how to shot wrong. So each patient, each image, each picture is for having the best and the most information from them. So fast review. This is normal, consider it normal. If you get picky, you can see some small fibroid, but still, this is a normal uterus. You can have it on 3D. Try to scan all the region of interest. You want to see the ovaries. Look for both ovaries. Look for the uterus. Don't miss the rest of the pelvis. Sometimes the symptoms are better explained with other things. Don't forget you're dealing with the person on the other side. There's an I and a you on the other side. So it's not about ultrasound machine like selling bread or a grocery store or whatever that you can be paid for. Just help the person and try to solve the problem, not becoming a part of it. Optimize the image, use the proper setup. The difference can be dramatic. Optimize the image, use the proper depth. No, you don't need 15 centimeters, 20 centimeters depth. You need 5, 10. Use the right transducer, play with the machine a little bit, or just click the proper setup, adjust the gain, the depth. Correlate in the brain, learn what's up, what's down, what's left and right side of the screen is the very basics of ultrasound. Now, once you figure out that and know anatomy, there you go. You're on your pathway to excellence. Whatever you do, do it in an excellent manner. And understand what you're looking at. Don't just play it normal or abnormal, just understand what you're looking at. We have excellent machines called brain, but sometimes our egos and biases get in the middle of the pathway between our knowledge and the social use of that knowledge. We are all very alike, and we are not perfect as we wish, or with the perfection definition of what we wish to be perfect. And not always the most common thing is the most normal thing. So in the end, and being a little bit of a philosopher, we are all damaged in some degree. Many uteruses are different, some more different than others. Is different normal or normal? Depends. It depends. A problem which is not causing a problem, don't make problems for that problem, because that problem can become a problem. It depends on the clinical scope. So try to explain the reason why the patient came into the examination, but learn how to tell the truth and how to tell, I don't know. Sometimes the right answer is, I don't know. Sometimes the problem stops being a problem. This is not a problem if we don't call it a pregnancy, because if we think pregnancy, we think baby, crying, peeing, and growing up. And if we manage improperly this information, we cause a grief situation. Every change in life causes a grief, a loss. And even when we win, when we improve something, we are losing something else. So careful. Our people needs more consolation than augmentation of the problems. This is, again, empty uterus, no free fluid, no pelvic mass, no filled bladder. We don't need always a filled bladder, because not every single patient has a thick layer of fat and a lot of intestinal gas. How the normal ovaries look alike? Well, like this one, like this one, like those ones, or even like this, because this is becoming more and more common. This is polycystic ovary. It will come time when normality is going to be the exception. This is a normal functioning ovary with a follicle inside. And in all instances, we should care the person. Don't forget about the person if no problem found, because still she has a problem. We all drown in an empty glass of water, because it's our own glass of water we can draw there. So, resuming, usually we examine the female pelvis because some reason. Western delay, pelvic pain, abdominal bleeding, pelvic mass, which we call the problem. But sometimes we see no problem situations, no problem things. This is a no problem situation. I don't know why the patient came into my sister's office, but apparently this was a normal uterus, normal uterus. But unlike X-rays, mammograms, other kind of studies, this is highly clinical. We perform ultrasound on patient's bedside. We see the person, we don't see images. If this person is 90 years old and has this endometrial image, something's wrong. If this person is 8 years old and has this endometrial image, and we are performing a vaginal examination on her, we both have a problem. So don't forget about the person. And if we have a fancy machine, we can document normality in a more evident manner. Nowadays, with the hysteroscopy boom, we need to see the endometrial lining more carefully in order to plan any further intervention. Is this normal? That's not a parasite. That's not a gold like that serious. This is nicely saying IUD inside the uterus. Is IUD normal? Well, it's very common for many patients to have an IUD. So if the IUD is properly set on the right situation inside the endometrial lining and not so low or high, consider it normal. I'm not particularly a friend of IUDs, but this is a normally set IUD. So differences on uterus that are not precisely critical abnormalities. First, we will see the very common findings. Bicornuate, septate, and polycystic ovaries. Remember, Mark, this is part of the former presentation we had before. This is uterus double image with the axial longitudinal plane of the uterus and the transverse planes of the uterus, which shows field bladder, thin wall, uterus, endometrium. This is one of the horns of a bicornuate uterus, because in the transverse view, we see two endometrial linings and both ovaries, one each side, one more anterior, closer to the skin, and the other one which is behind the bladder and besides the uterus, somehow in a deeper position. Sometimes, and everybody has the right to have two blessings, two problems, two differences. This lady had a bicornuate uterus, not very evident on the surface, but readily evident on the endometrium. We can see two endometrial linings separated by a myometrial pattern with no difference on the surface of the serosa. This is the right side of the uterus. This is the left side of the uterus. And this is the right ovary. I try to accommodate the images the friendlier to the brain as possible. So this is like looking at the patient from the frontal view, facing the patient. This is going to be the right side ovary at my left hand side. And this is going to be the left side ovary. It always helps to respect ergonomics, to be comfortable and to be good with the brain, not to make the brain to do a double effort trying to figure out which side is which and what's going on. So during scan, how does it look? If we go all the way up from above the pubic bone and find a notch, and then tilt the transducer sagittal and see, like in this case, 2 endometrial linings. Well, by the way, one with the pregnancy, the early pregnancy. That way we are fairly sure that it is a typical shaped uterus, not a double uterus, but a tabicated uterus. And this is the transverse view, and this is the axial, longitudinal, sagittal, whatever you can call it, view, the metrium, gestational sac. They look like this, sometimes with a mild arched form on the endometrial lining here. And sometimes they look like this. Like this. But we don't need the fancy machine. This is enough. And this can be performed with any ultrasound machine of the world, even with museum stuff. I have a small portable one transducer in a hand, well, 2 transducers. It has a linear transducer on one side and a convex transducer on the opposite side. And it's like $2,000 to $3,000 machine. You can transmit via Wi-Fi to your cell phone or tablet. It's not the kind of thing that you cannot buy. And you can do this with search machines. You don't need the Voluson E6, one of the better machines ever built. Sometimes the position of the uterus is not the commonly called normal position. We call more normal anteverted uterus, which means the fundus pointing to the surface of the anterior abdomen. And somehow not that normal, the retroverted uterus. But usually this is a matter of how this lady was constructed since before birth. This is genetics. Some uteri are pointing up or front. Some uteri are pointing back. This is not a normality. This is a difference. This is a different uterus, slightly bicornuate, with two endometrial linings separated and retravated. Again, skin, fat, muscle, fascia, bladder, uterus, rectum, more intestine, air, right side of the patient, left side of the patient in the transverse view. And some bicornuate, tabicated, septated uterus have an IUD. Guess what happens if you have an IUD in one of the uterine cavities and the other uterine cavities not with an IUD? Left horn, right horn, septum, two cavities. This lady thinks she's not gonna have a baby because she's fully or almost fully or enough protected with the IUD. But she didn't knew before that she's not the ideal patient to wear an IUD because she has two, for practical purposes, two endometrial cavities. She would need two IUDs. And a doctor wise and skilled enough to put one IUD one side, one IUD on the other side. That's like, no. But it worked so far. And she's got no pregnancy, in fact. And we can make reconstructions and trials to image that IUD with nice pictures. You don't need a nice picture to be part of the solution. You just need will, skill, and the chances and the patience will come. And you will become part of the solution. Sometimes there's an abnormality, a real abnormality or problem in one side of a septated uterus. Like in this patient, this lady who had cramping and sided cramping, and she has a sided hematometra, which means, of course, collection of blood, mild, in the right cavity of a septated uterus. Again, what we see here, I cut some parts of the image so we can focus on the information we want, but believe me, skin is up here. As usual, the bladder is on the right side of the screen, left side of the patient, looking at her from the sagittal point of view. One of the horns empty with the linear endometrium. One of the horns with a mild collection. And we can do a volumetric render, a nice reconstruction of the two cavities in order to demonstrate the enemy, or not the enemy, the colleague, what we are looking at, and how good we are with images. But this is enough. This is enough. We don't need fancy machines to be a part of the solution. We need skill, will, and the right patient will come in. This lady was born like this. We can call others names. Anyway, we can, we are free. But this lady is not a freak. This lady is a human being with a difference. This lady has 2 uterus. A uterus which is divided, or to tell it more properly, a uterus which is not properly fused on the center, because we all are made of 2 halves that become attached in the middle, and the single organs are usually part of 2 halves which are modified on our own evolution in womb. And this lady had no fusing of the 2 sides. Double uterus. She's not like others. She's different. And in the transverse way, in the transverse evaluation, we can see this. The uterus. We are here at the level of the pubic bone. We started on the fundus. This is a difference. Abnormality, a variation of form of the uterus. This can be a problem. But I've seen full-term babies to be born from double uterus patients. And in fact, I've seen fabricated, septated vaginas with natural birth. I mean, we can be a part of the solution, not necessarily part of the problem. So this is more common than we could think. To have a septated uterus with a pregnancy, and septated uterus are better diagnosed in early pregnancy. In fact, this is easier to diagnose in early pregnancy than in non-pregnancy, because sometimes with a non-pregnant uterus, we miss this. We miss the notch. We just have an image like going in front of the mirror, and then our brain can ignore that, can choose to ignore that and call it normal, typical. This is normal, a nice vaginal scan of an ovary. In fact, you can even see the oviduct here. See that? Two days ago. So what happens whenever people says, my ovary is hurt, I have pain on the left ovary, pain on the left ovary. Probably number one cause of getting into my office with pain. I have pain on the left ovary. Or somebody suggested that it was an appendicitis on the wrong side, by the way, and had pain on the left ovary. What I most commonly see is the descended colon, the large intestine, on the part where the sigmoid here and the descended colon here attached or continue one with the other, spastic, contracted, hurting. This has almost no air inside. We don't see those white bubbles with nothing behind. We see the anterior more close to the patient's skin wall of the large intestine and the posterior wall of the large intestine with some edema. That's why we see it dark and thicker than usual. And this is the intestinal lumen. The feces were stripe-like because this is tight, pressing, hurting. See this? This has a maximum lumen of 1.1 centimeters, which is not the lumen, it's the thickness of the wall. And she came in and said, I have pain on the left ovary. No, that's colitis, irritable bowel. It's different between what's happening on the outer world. You cannot change it. You cannot change the pandemia, the lack of work, of jobs, the need for more decent income, but you can change what you eat. So take control of what is under your control, what you put in your mouth. There's not a nice way to suggest that. One of the most dangerous places where you can get in is between somebody else's and his or her fork. Careful. Anyway, care the person, not the problem, especially if no problem found. With, without, regardless the problem found. So, not always common is normal. You will see more and more of this. And you can look at it with a convex normal probe. This is a vaginal probe. And a frankly polycystic ovary. There's no question about it. You don't need to count the follicles. Some people ask, how many follicles do I have? How many fibroids do I have? How many gallstones do I have? Then you have to explain, well, it's not how many you have, it's how you feel. How does it look? and how you feel and what you wish to accomplish on life. You want to have children, you want to be healthy, you want to chase grandsons. Well, you better change your feeding habits, because if in 15 years you had a kid, you want to dance in a 15 years old party, and you are lying on the bed with a diaper, the only thing you will hear is, who's gonna change my mommy's diaper? That's not nice. And people doesn't come inside the office to hear that. But our people deserves to be well informed and aware of what's happening. For once, somebody tells in the better manner possible, there are better chances to be happy than keeping doing the same. Because if you just do the same, all that you will get is more of the same. So this was a nobody, because this is intestine. And this lady said, ouch, when we press here. If the lady says, ouch, when you press the intestine, then what's the meaning of that? You press the ovary and not a gesture, but you press there and says, ouch. As one of my professors said, scan where it hurts. And you can have that phrase backwards and say, if it does hurt where you're scanning, problem is there. So this was a lady with a polycystic ovarian disease with pain due to irritable bowel, colitis, call it as you wish. Sometimes mild diarrhea, sometimes mild constipation, sometimes alternate between constipation and diarrhea. You have a call to go to the bathroom, then you go and do nothing. That's the most common cause of pelvic pain and pelvic examination due to pain. Irritable bowel. And once again, you can see nicely seen ovaries with all the structures surrounding. Other not so abnormal things. If I locate the ovary and see a cyst outside the ovary, clearly not related with the ovary, this is the kind of cyst that usually just messes with us. No pain. See how I pressed? This is a second opinion referral. Somebody else told the lady, you have an ovarian cyst, right side. Believe me, this is right side. What could we notice here? See details. Microconvex, meaning endocavitary probe, transvaginal, to look at the ovary. This convex, it's not transvaginal, it's the convex probe. We are high. This is intestine. We don't see uterus. We don't see the ovary. We don't see here any of the pelvic organs related to that. We actually see the second, the right, the ascendant colon, and then the cyst. Lateral to this, this is the normal right ovary. This is the cyst, and it's not an ovarian cyst. This is what we call a paraophorus cyst, fluid-filled thing hanging from the mesosalpinx, with just difficult diagnostic. If this lady comes with colitis, and we call it an ovarian cyst, we can be part of the problem of sending somebody to unneeded surgery. We are becoming part of the problem of sending somebody, contributing, being accessory to an unneeded surgery. If I do that and doesn't hurt, and I scan where it hurts, and it's not here, but here, it's not the ovary, nor the cyst, which is hurting, but the intestine. Don't be afraid. We are not just taking nice, perfect pictures of things. We have the right to express our first-hand opinion of what happened during examination. If I press the intestine and that makes the patient say, ouch, don't be afraid to call it colitis. Mention the cyst. Then write up an observation and say, you know, it does hurt when I press the intestine, not the cyst, and this kind of cyst, which is not ovarian, which is not follicular, which is not luteum, which is not endometrial. Endometriosis, chocolate cysts don't look like that. Usually are not that rounded, that limited, that encapsulated, and that homogeneously anechoic. So this is not the cause of the pain. Don't become the cause of the problem. Who knows what's going to happen during any surgery, particularly if it's on unneeded surgery. Again, pain in the ovaries with normal ovaries, it's not the ovary. Spastic colon, #1 cause of pelvic pain. Sometimes we can document such things like a cramping uterus. See the movement of the endometrium. We can see cramps. Take as much as you can from what you're looking at. If you just see the cramping uterus, you can miss this nice left side multifollicular ovary, small sized, many antral follicles, immature. You can miss the other side ovary. This is around here, and I'll show you. So that right ovary. Oh yes, we have a cramping uterus, but here, as we don't usually send video clips, we send an image, and we say, normal endometrial line. Oh, by the way, we saw changes of shape of the uterus, which usually I've seen during cramping. A normal multifollicular. This can be normal early cycle ovaries, not necessarily polycystic ovarian disease, especially in particularly if that's not the problem. Again, most of the times we have big mouths because we want to prove how good we are. Cramping uterus, ouch. What we can miss too. This is a slightly arched uterus. See this? I was telling you about the 16 shades of gray. The machine has like what? 256 shades. The human eye discerns around, well, 16 probably. If you pay enough attention, you can discern 64 after this chat. What is normal? We can consider normal that what is predictable. Is it predictable to have abnormal bleeding after taking the so-called emergency pill? I don't get into ontological discussion about emergency pill, but well, the pill is intended to stop an early pregnancy, not necessarily to prevent a pregnancy. That's an euphemism to call it. Well, that's a fact. If you took an emergency pill and you have abnormal bleeding and this image, this is not a situation of perfect health. Or this was highly predictable because this is an early miscarriage. Almost without the biopsy of this. This is an early miscarriage. That's the impact of an action, of the best decision that was taken by the person with the best knowledge of the situation and in good faith. She did the right thing. on that moment for her. And we should respect that. But now there's a consequence. We can see and measure the consequence. And normality of endometrial lining is between 5 and 5 millimeters, resting endometrial, what, 10 millimeters, secretor endometrial, but not this heterogeneous thing that we see here. So she will need to take more pills in order to get this out, or intrauterine aspiration, or even a DNC. It's not normal. But it was predictable. And it's nobody's fault. It's just the fact that in our diagnostic brain, many things are predictable. There's no harm in asking about the whole situation before we see the patient or during the examination. Sometimes I do this and I start asking, did you took any medication? No. Oh, yes, by the way, I took an emergency pill on that day. Oh, okay. Well, what's happening is that the pill is doing its work, its job. Your uterus needs to be cleared up. The cramping and the bleeding is because the pill is doing the job. Without demonizing things. Why? Because we care the person. Particularly if we have a no problem situation, or with, without, and regardless the problem found. So, there are several arguments for asking pelvic ultrasound. Abnormal bleeding, abnormal menstruation, pelvic pain, a palpable mass or suspicious of mass. And the causes, not all, but the most common causes are pain, irritable bowel. It's not like we don't have twisted ovaries, tumors, endometrial cancer. We will see this next week. Next week, we will go through the whole scope of abnormalities, more abnormal abnormalities, if you allow me the redundancy. Fibroids, which are not always a problem. They're a problem if they are a problem. Unusual problem of fibroid is bleeding. Fibroids don't hurt. If it does hurt, it's not a simple fibroid. Usually, generally speaking, fibroids don't hurt. And most instances of a palpable mass, we find no mass at all, or a fibroid, or pregnancy. Again, care the person. Why? Because it doesn't matter if we call this patient normal. They always ask, if I'm that normal, why is this happening to me? They came in because of a reason. We find something right. It's easy to see an ectopic pregnancy, a, 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 dermoid cyst, a normal pregnancy, an abnormal endometrium, a twisted ovarian cyst. The harder part of our practice is always when we don't find an explanation of the complaints of the patient. She can be drawing in a glass of water empty, but she has the right to feel like drawing in that glass because it's her empty glass of water. If we find this to be a no problem situation, we just tell them the truth. Oh, you know what? This happens to 70% of all pregnant women. If you have a positive pregnancy test around the timing of your menstruation and then menstruate, that's not unusual. Don't call it a miscarriage. That's pretend you never had that pregnancy test. No consequence. This is good news. This is the best news. You don't need anything. You don't need antibiotics. You don't need an ANC. You don't need to worry. You don't need to be sad. This is not because you did something wrong. This is not because of the moon, of the sun, or of the chapter of the Kama Sutra you were practicing with your husband. This is not your fault. This is what usually happens. You don't have the obligation to know it beforehand, but now you know it. Believe me, I'm a professional in this. This can happen to anyone. You're a young, otherwise healthy woman with those ovaries. You will have as many children you would have. Not precisely as many children as you wished, because hey, nothing is as we wish. But I find no problem, and I know how to do my job. What can I guarantee you? You don't need a medical intervention because of that menstrual mild delay of a couple of days and then an unusual bleeding. This is a common thing. Don't become a part of the problem. Remember, we're dealing with persons. Optimize image. Use the proper setup. Use the proper transducer. Beware of your numbers. You have a social impact. We all have a social impact. Manage your debt. Pick a good transducer and the proper setup, gain and depth for that patient. Understand on your brain what you're looking at above, below, right and left side of the screen, and know a bit of the anatomy. This is simple. One ovary each side and a uterus on the center. Don't believe everything I say. I sent back a patient once with a situs inversus diagnosis, and she was referred for a pelvic examination. And the referral physician asked me, how come you figure out she had the heart on the right side, the liver on the left side, the gallbladder on the left side, everything on the opposite side? Well, I told him, I saw the ovaries and it called my attention that the right ovary was on the left side and the left ovary was on the right side. And he like swallowed it like without chewing it. And a couple of weeks after that, he was looking for me. to complain about the lie I told him. Well, there's a difference between common sense and logic. Common sense is the less common of the senses, doesn't need much of knowledge. Logic needs knowledge. Knowledge is to know that many uteri have slight differences, small fibroids. Don't call it abnormal without a reason. You can expose somebody else to an unneeded intervention. Take a look at those ovaries again. This is normal. This is still normal. They don't look alike. They are different. We all are different. Ovaries are dynamic organs. They change from one month to the other, from one side to the other. There's not such thing as alternance of ovulation. You don't have ovulation on 1 month on the right, 1 month on the left. That's not true. If you have just one ovary, you have ovulation over one ovary, and that's it. But you have both ovaries, this is not predictable. Which side is going to work which month? And both ovaries will look different. Different sizes, different relative positions, and they can have different pathologies. Polycystic ovarian disease is common. Don't call it normal. Not every multifollicular ovary is polycystic. This is polycystic. This is a functional anechoic image inside an ovary. You see it big because we have a big machine. But it's not a big ovary. It's a 4 centimeters ovary. Get the person, and don't forget, people is not the problem. We are not the problem. And that's not an implant from the other space. There are differences, some more dramatic than others. There are differences which are normal variations of anatomy, like retroverted uterus. Difference that are not like considered normal variations of anatomy, like septated uterus. Abnormalities that are not critical and allow people to have normal lives. Finally, it has explained the clinical scope. This lady had pain. We have now explanation of the pain. Try to explain whatever people feels. And always ask, what else? Sometimes we don't have the time, but most times we don't take the time. People needs more than a highly skilled technician, physician, assistant, midwife. They need people to care for them. And we all need people to care for us. This is a matter of fairness, not justice. But the most evident things, we can explain it. by looking inside. This is a miracle. We are looking at inside bodies without opening it. This is the contemporaneous face of a real miracle. There's always a denial part of the information. We all work on our systems with 3 levels of reasoning and acting. The hard data level, which resides on the prefrontal cortex, the brain, the limbic centers, which are the residents of our emotions, and the reptilian brain, which just are the places where some instincts like run, fight, and copulate are. We are not machines and we are not animals. We are normal human beings. Whenever I tell somebody, anybody, you have colitis, you should change what you eat. It doesn't matter if I have the hard data, the evidence. I've seen ovaries normal and I see the intestine and I press the intestine and what hurts is the intestine and I see a spastic colon, evidence, hard data to store on the brain. That person will not decide or answer back from the brain, but from the emotion. And the first thing they think is, this doctor, I came in with the pain on my ovary and he's telling me I'm fat and I eat junk. I hate him. That's normal, that's emotion. We are human beings. So be careful, but don't tell lies. Gradual changes on human bad habits are to be accomplished with our help. If we are wise enough and we become more interested on people than on images. This is very nice, but care the person. Do your best. Play excellent with whatever machine you have. Be picky, be accurate. Scan where it hurts. Don't assume things. Don't let the emotion rule. And don't let the ego get in the way between your skill and the other one's health. Get the most from every single image. It's not always the nice, uncommon, unique thing what you need. You need to print a picture of what ovaries and describe it, or just describe it. Ultrasounding can be an act of faith whenever you don't print images, but your referral people knows you. They know if you exaggerate or fairly speak of what you found. Don't be afraid to tell, well, the pain is not related to that. Because I press that, and it didn't hurt. Use logic, not plain common sense. You have knowledge. You know what happens after you take the emergency pill. Don't play numb. Care the person, carry yourself. You deserve to be self-recognized as a fair human being. And I think we cover what's normal. And above all, there's plenty of images online. You don't need me to get the brain filled up with images of what's normal and what's abnormal. You just need to scan every person that gets in, scan everywhere. Scan the gallbladder, scan the liver. You will learn. The more you see, the more you'll find out. The smoother your sensitivity and specificity will be. You will be as specific as you can with the knowledge you have, and as sensitive as you can with the skill, the experience, and you will eventually get here. Questions, comments, welcome, and spread the people my email address.
Wow, that's so exciting. Fully loaded. You are such a genius. Yeah, you are such a genius. Yeah. So it's a pleasure having you for today. What we'll do is we'll note down the necessary questions, and then we'll send it to you. Then
Send it to me.
hopefully next week. Yeah, and hopefully
And next week
before we
I can send back the answers.
Yes. So that before we start next week's session, we'll go through with us the questions before we start. Yes. Then lastly, when you are less busy, you can share the slides so that they can also peruse it.
Sure. I will get the pack, send it to you, and you can freely share it with the people.
Yeah.
And as well as the recording.